Hello everyone. I, Dr. Seema, on behalf of RRTC's team, welcome Dr. Seema Hakim and all the participants to attend this very important session on cord prolapse and fetal distress. Thank you everyone for coming and joining this session. Over to you, Seema. Thank you.
Today's session is going to be on cord prolapse and fetal distress. So both these topics are very important, and they are the reason for obstetricians' distress as well, because it's such a dire emergency that we also start feeling the distress when there is a cord prolapse or fetal distress for any reason. So the topic is going to be important, and I hope you will enjoy today's session. With that, let's come to the agenda. I will have some presentation. So what is actually cord prolapse? So you can see in this picture, the cord is ahead the presenting part of the fetus. Here the head is the presenting part, and you can clearly, evidently see that it is the occipito-posterior position. As you can see on your screen that occiput is at the, just see it is on the posterior side and sinciput is anterior. So it is occipito-posterior. May not be visible. We will subsequently come on to this problem. So you can see on this picture on your screen, one is occult cord presentation. I'm sorry, it is wrongly written prolapse. This is not occult prolapse, but this is occult cord presentation, wherein the cord is presenting by the side of the head. So it may not be palpable, or when you do a pervaginal examination, you may not be able to feel the cord. Maybe if membranes rupture and you insert your finger further in, you may be able to feel the cord, but mostly it is not felt. So when do we suspect an occult cord presentation? You are auscultating the fetal heart sound and you feel that there is variable fetal heart sound. That means there are variable deceleration in the fetal heart sound. So you should suspect that the cord might have entangled around the fetal body, or maybe I am dealing with a case of occult cord presentation, and I should be careful when I am monitoring such a labor, as there is a risk of more cord compression, and cord prolapse may also occur with the membrane rupture. Second picture which you can see over here, the middle one, what happened? The second picture which you can see is that of a cord presentation wherein membranes are still intact. So with the intact membrane, remember, if the cord is ahead the presenting part, it is called cord presentation. Now, if the membranes have ruptured, then the cord will likely to come out of cervical canal to vagina, or maybe outside the introitus, and this is called occult cord overt prolapse or cord prolapse. In short, we call it cord prolapse. Moving ahead, this session is with the objective that by the end of the session, the participant will be able to diagnose and manage prolapse of the umbilical cord. So umbilical cord lies in the birth canal below the fetal presenting part. So, and it may be visible, as I have already said, or it may not be visible outside. Now, as to, it's a dire emergency. यानी कि एक ये ऐसी इमरजेंसी सिचुएशन है जहां which requires very quick, fast reflexes of obstetrician. They have to be very fast in managing a case of cord prolapse. So, and the problem is may not be with the mother, but the problem is with the fetus. Fetus is suffering because of the cord prolapse. So, if it is compressed and it is left for a long time, lying outside or getting compressed, then it will lead to intrauterine fetal death. So we have to be quick in relieving the compression and managing the patient. So we have to give oxygen at the rate of 4 to 6 liters per minute by mask or nasal cannula immediately. As soon as we get a case, we have to give oxygen. Then what else? Now we have to do a proper examination. It's not just a PV examination. We have to be very quick, fast, but do a abdominal and vaginal examination apart from general condition. So alone you will not be able to do. So as soon as you suspect a cord prolapse, you call for help. That is important, and try to find out that what is the gestational age of this case, whether fetal heart is, I can auscultate or parabdominal examination. On PV examination, how much is the cervical dilatation, up to what station the head has descended down, and whether I am able to feel the cord pulsations or not. So all these things are very important, especially whether the baby is alive or not, and at what stage the patient has come. If the patient is being brought to you and by the time she has come, there is absent fetal heart sound and cord pulsations are not, they are not there. That means IUFD has already occurred. So you can wait for a spontaneous vaginal delivery and manage. But if cord pulsations are there and baby is live, then you have to see that whether I am going to deliver her vaginally, depending on if the head is quite low down, deep into the pelvis, and there is imminent vaginal delivery, or the vaginal delivery is not expected immediately, imminent vaginal delivery is not there. Maybe she is fully dilated, but the presenting part is still high up. Maybe I am dealing with a case who have abnormal presentation like occipito-posterior with head high up. Maybe she has transverse lie. Maybe she has breech. So all these conditions have a higher chance of having a cord prolapse. So to say it once again, it is a breech presentation, transverse lie, occipito-posterior position, and twin pregnancy. They have a higher chances of having a cord prolapse. So what do you see in this picture? What is the obstetrician doing over here? She is doing a PV examination. So cervix is not that much dilated. PV examination, feeling for the dilatation, feeling for the cord, and at the same time, once she gets a case of cord prolapse, immediately what she will do, she will try to push this head up. So with the finger, try to push this head up. Why? Because otherwise you see, here is the cord, here is the head, and if it is getting compressed between the bones anteriorly and posteriorly, the risk of fetal distress will be there. So as soon as she will see a case, she will try to dislodge the presenting part and try to relieve the pressure of the head onto the umbilical cord. And then there are certain positions which are going to be of help in relieving the pressure onto the cord. Apart from this maneuver, which is relieving the pressure on the cord, the second thing which can be done is, once the pressure is relieved, one assistant can apply a suprapubic pressure upward. Yani ki yahan, putting the hand here, applying the pressure upward, that means this will displace the head up. And we want the head to be displaced up so that it is not compressing between the bone, the umbilical cord. Then certain positions which are going to be of help in these conditions. I hope you can see on your screen the picture. This picture is very clear. So this is the Trendelenburg position. So putting the patient in this position, the gravity plays an important role. So head which was coming out or presenting part, this will be displaced up. So this is based on the principle of gravity, that we are displacing the presenting part up. Or the other condition is knee chest condition. So knee chest position is again the basis of knee chest position is anti-gravity. So it with the gravity force, if the head is or baby is coming down, it will prevent the presenting part coming down, so relieve the pressure. Then the third position, which is very comfortable for the mother also, left lateral position, in which slight modification of the left lateral position, which is called Sims position, in which one leg is extended and the front leg is flexed, and a pillow is put behind, below the pelvis. So putting a pillow below the pelvis and keeping the position like this will cause displacement of the head, and it will relieve the pressure of the head on the umbilical cord. Now, you may have a situation where cord prolapse has occurred in your labor room, where you are fully equipped for doing cesarean section. So in that condition, what you can do, you push the head up by your finger and transfer the patient to operation theater. Keep it like this. Keep the pressure on the umbilical cord relieved. Call anesthetist. And your helpers are already there. Maybe your senior obstetrician is there. So she will do, the anesthetist will give anesthesia, because here general anesthesia can be given. You can't make the patient sit up, because this, if for spinal, if you make her, is it connected? If you make her sit up, then what will happen? The head will compress onto the umbilical cord more. So a general anesthesia is given. The obstetrician will clean and drape the abdomen, and once she has started giving the incision, you can relieve your hand and she will immediately deliver out the baby. This will certainly improve the prognosis. Now, the situation may be that it has occurred, but you don't have the facility. Maybe you are working in a PHC and you don't have a facility of doing a cesarean section at your place. So what should you do in that situation? You have options of transferring the patient in a comfortable ambulance. You can't transfer the patient in knee chest position because it will be dangerous. You can't transfer the patient in Trendelenburg position. So what position is left for you, which is comfortable and safe also for the patient, is the Sims lateral position. She can lie on the stretcher in Sims lateral position and with a pillow beneath her pelvis, so that it is getting relieved. It is not getting compressed. And if the umbilical cord is lying outside the vagina, and so you just take a moist, sterile gauze and replace it into vagina. Do not make an effort to replace the umbilical cord in the uterine cavity. So remember, no effort should be made to replace umbilical cord in the uterine cavity. All that you have to do is gently deposit back into the vagina, whereas it is wrapped in a saline soaked sterile gauze. The other thing which you must be doing when you are transferring the patient apart from this Sims lateral position is fill the bladder, retrograde filling. You can see on the screen the retrograde filling is being done. This is normal saline. You connect it with the catheter, urinary catheter, self-retaining Foley's catheter, and put at least 500 to 750 ml of normal saline into the urinary bladder. Putting filling of bladder will relieve pressure onto the umbilical cord. This will definitely relieve pressure on the umbilical cord by displacing the head and relieving the pressure on the umbilical cord, and you can transfer the patient in this condition. But everything should be documented: at what time the patient reported to your center, at what time membranes ruptured and you noticed a cord prolapse. When you noticed, immediately you took the measures of putting the patient in knee chest position and asking and filling the bladder, asking for an ambulance to transfer the case. All these things should be clearly mentioned and should be told to the patient also that we do not have the facility, so we cannot operate her, and she needs to go to a center where the facility exists for doing a emergency cesarean section. Now, if maybe she will progress in labor, becomes fully dilated and start delivering vaginally, or maybe she is taken up for cesarean section. But in all these situations, the bladder has to be deflated. So at the time of normal delivery or at the time of C-section, the bladder needs to be deflated well. Okay. So after deflating the bladder, you do a cesarean or you do you conduct a normal vaginal delivery, right? So this slide shows what all you know now, most of the things, but just a quick revision of prolapse cord in first stage of labor. Push the presenting part up and decrease pressure on the cord. Dislodge the presenting part from the pelvis. Place the cord in the vagina if lying outside, but do not try to put it above the presenting part. Put patient in Trendelenburg or knee chest position. Insert Foley's catheter in bladder and inflate it with 500 ml saline and clamp the catheter. Of course, if you will not clamp, it will drain out everything which you have filled with so much of difficulty. You can go up to 750 ml, although here it is written 500 ml. Then place other hand on the abdomen in suprapubic region to keep the presenting part out of the pelvis. Once the presenting part is firmly held above the pelvic rim, remove the hand from the vagina. Once you are sure that your abdominal hand has displaced the presenting part up, you can remove your hand from vagina. You all have experienced that putting the hand in the vagina for longer time may be discomforting for the patient and for the obstetrician both. Then on abdomen, you will have to keep the hand firmly so that the head doesn't, or presenting part doesn't come back to pelvis again till the facility for cesarean section is there and cesarean section is started. Then quick cesarean section will definitely improve the prognosis of the fetus. Then in second stage, if it has occurred, so it will depend on the station of the head. If the station is low down, then you can apply vacuum or apply forceps and deliver out the baby. But if breech presentation is there and baby is not very big, you can do a breech extraction, taking adequate precaution when the head is being delivered, because what happens in breech presentation, people will pull leg, pull the upper arm and then start pulling the head, the rest of the body. So this will cause extension of the head. So all effort should be made to prevent extension of the head. Once you have done an extension of the head, it becomes so difficult, and the mortality, perinatal mortality and morbidity is also very high. So here extra precaution should be taken to deliver the after coming head of the breech, because easy to deliver trunk but difficult to deliver head if you have not taken adequate precaution. And of course, pediatrician or preferably a neonatologist should be called for the resuscitation of the newborn, because these newborn definitely will need a resuscitation, and expert only will be able to do a intubation and timely intubation to resuscitate the baby. Moving on. So if the cord is not pulsating, but you should be sure, you know, sometimes what happens, the cord which is prolapsed in the vagina and it is compressed also, and so like the temperature difference is there, so maybe vasoconstriction of the cord is there, so you may not be able to feel the pulsation properly. Sometimes you become nervous and not able to feel the pulsation. Always try to make an effort to make sure that fetal heart is absent by auscultating through the Doppler per abdomen. If you have an ultrasound facility available in the labor room, you should confirm it by the ultrasonography before labeling the baby dead. So very carefully you have to find out whether the cord pulsation is really absent or you are not able to palpate the cord pulsations. Now, if you have made sure that this baby is dead or baby is too small, very small baby, just 22, 24 weeks baby is there, and you are not going to gain anything by doing a cesarean section, then you can wait and have a, like you can induce the mother or you can expedite the labor to deliver the mother vagina. But be very careful if you are dealing with a case of transverse lie, baby is not very big, then in that situation, you can do a internal podalic version and breech extraction. But if transverse lie is there, cord prolapse is there, or in other case where the baby is big, and normal vaginal delivery is not possible, in that situation only, even for a dead baby, you may have to do cesarean section. Otherwise, you should aim at having a normal vaginal delivery in cord prolapse with absent cord pulsation and a dead. Okay. Now, moving on to another very important topic. Before I start with this topic, I will tell you about a joke. So when I was doing my MD, that was way back in 1985-86. So there came a joke. So what are the indications? The student was asked about the indications of cesarean section. So it started with like maternal distress, fetal distress, obstetrician's distress. So the examiner asked, what is this obstetrician distress? Where have you read this from? So obstetrician distress, sir, I have read it from 20th recent and 10th stud. Those were the recent advances books. और वो आई भी नहीं थी उस वक्त, थर्ड और फोर्थ चल रही थी recent, and ऐसे ही 2 or 3 volumes of stud was there. So the answer was that 20th recent and 10th stud. So the obstetrician, although obstetrician distress is important, you know, many a times obstetrician, they get really distressed by patient shouting and they are worried कि बच्चे को कुछ ना हो जाए और cesarean section होने लगता है. And in many people have reported that most of the cesarean sections are because of obstetrician distress. But anyway, there are genuine cases of fetal distress also where cesarean section is done, and sometimes cesarean section is not done for fetal distress and the baby suffers with the sequelae. So fetal distress is actually the distress is the manifestation of fetal hypoxia. And if for prolonged time, prolonged decelerations are there and it was missed on CTG, or for long time fetal bradycardia was there. It can lead to fetal death. How do you diagnose during labor? During labor, of course, one is abnormal fetal heart, bradycardia mostly. Initially, there can be tachycardia, but that means persistently very high fetal heart rate without mother's tachycardia, like no fever, nothing is there, but fetal tachycardia is there. So that is also a sign of fetal distress, but later stage bradycardia is there. Along with that, meconium stain, sometimes very thick meconium stain, Liker is there, that is a sign of fetal distress. So what happens actually in fetal distress? There is, and there can be antepartum already, like who are the cases who have already antepartum fetal distress? The cases of intrauterine growth retardation and antepartum hemorrhage, mostly accidental hemorrhage. But to cause fetal distress and death, more than half of the placenta should be separated. So in antepartum period, important causes of fetal distress may be there. And then in intrapartum period, like in antepartum period, maybe there was no distress, but as soon as uterine contraction started, so the distress, because the baby was already compromised. So baby will not withstand the uterine contraction and will develop fetal distress. So what is neonatal asphyxia neonatal? If baby is born with low Apgar score, already fetal distress was there, and the baby is born with low Apgar score, we call this condition asphyxia neonatal. It is already there in intrapartum period, and the baby is born with the less oxygen. That means it is a distressed baby which is born. So for intrauterine fetal distress, maternal hypoxia may be there, like anesthesia, heart failure, severe anemia. We all know that oxygenation of baby will be less, and it is a very common problem in our country. Then during eclamptic fit, so patient withhold the breath during eclamptic fit. Kya hota hai? She withhold her breath for at least 1 minute or even longer. So this time maternal oxygenation is very poor, leading to poor placental transfer of oxygen, leading to distress. Then pulmonary disease, of course, oxygenation. If oxygen exchange through the lung is not proper, this will lead to maternal hypoxia. In turn, it will lead to fetal hypoxia. Then placental insufficiency, like intrauterine growth restriction, we have already talked about. Then prolonged labor. So placental insufficiency will be there in prolonged labor. How? So for so long, if the uterus is contracting and the labor is not getting progressed, it will cause placental insufficiency. Then tonically contracted uterus. What are the situation? Injudicious use of oxytocin will cause tonically contracted uterus. Then placental abruption may be there. Then uteroplacental insufficiency. Then fetoplacental. Uteroplacental insufficiency का मतलब क्या होता है? Uterus से placenta में circulation कम जा रहा है. So that is uteroplacental. Fetoplacental is placenta तक तो जा रहा है, but fetus में कम जा रहा है. Then that is called a fetoplacental insufficiency. The marker for uteroplacental insufficiency may be from the uterine artery, the flow is less. But most of the babies, they will maintain themselves, even if some less flow is there to the placenta, adequate amount is there through the placenta to pass on to fetal. And fetoplacental insufficiency, the marker is color Doppler. Umbilical vessel circulation is seen. So if there is jeopardy, then there will be more resistance in the umbilical vessel circulation. That is why every case of intrauterine growth restriction, if we are monitoring them for proper time of delivery, we monitor them by doing a umbilical cord blood flow study. So umbilical cord blood flow study will tell us that now this baby is has started suffering and we should deliver out the baby. Then some vascular anomaly of placenta and cord can also lead to fetal distress. Then small placenta, abruptio placentae we have already talked about. So, and post-term, where aging placenta in post-term is there, that can also cause fetal distress. Then certain anomaly in the cord, like what is true knot and false knot, these are also there. False knot, of course, is not dangerous, but true knot may be. If Potter's jelly is less and it is tight, it can be dangerous for the baby. Then cord round neck, sometimes, multiple loops of cord round neck are there. But, cord has enough amount of Potter's jelly and it will not let the cord vessel compress because they have encircled the fetal neck. Many times, many obstetricians, they will advise for cesarean section for the reason that there is cord around neck and cesarean section. This is not an indication for cesarean section. Many baby will have cord round neck who deliver normally and without any distress. All that they need is to watch them during labor to see the descent of the head, and they have a normal delivery. And during delivery process, the cord should be slipped over the fetal head, or if they are tied, they should be clamped and divided. Okay. Then vasa previa is one condition where vessels, they are ahead the presenting part and they can sometimes rupture during labor. So in vasa previa, fetus bleeds. And you know that fetus has 70 ml per kg body weight of blood volume is there in the fetus. So if they start bleeding, a few ml of blood loss may be very significant for the baby and they manifest as fetal distress. So in antepartum hemorrhage, yani ki placenta previa and accidental hemorrhage, mother bleeds. Fetus does not bleed. But in vasa previa, who bleeds? Fetus bleeds. So even small amount of blood loss from the fetus means a lot to cause fetal distress. So then rarely hematoma of the cord can be there. Like mostly, hematoma of the cord will be formed by doing some intrauterine invasive procedure like cordocentesis. Cordocentesis का मतलब क्या है? Cord needle डाल के antenatal period में cord बच्चे की cord से blood लेना, like in RH incompatibility or other suspected anomaly where we want to do a chromosomal study. So in that condition, cordocentesis is done, which can cause hematoma of the cord. Very rare. Then, of course, we have already talked about prolonged compression of the head in cord prolapse. There is one more condition where prolonged compression of the head of the, prolonged compression of the head is there in the obstructed labor. So in obstructed labor, there is prolonged compression of the head. Of course, prolonged compression of the cord with the head can be there in a cord prolapse cases. Or if there is reduced Liker amnii, patient is in labor, there is cord compression because during labor because of the less Liker. Liker क्या करता है cord पे cushioning effect देता है. So if the Liker is being drained out, there will be direct compression on the cord leading to fetal distress. Then prolonged, of course, prolonged labor we have already talked about. Obstructed labor will cause prolonged compression on the head leading to compression of the respiratory center and problem will be there. This picture on the screen shows a true knot. Actually, this true knot, what is this true knot? You can see it more clearly over here. इसमें ये रहता है कि baby has passed through a loop of the cord and it has made a knot. So this is called true knot. This picture is showing a false knot. False knot, you will, when you conduct delivery and examine the cord, many times, there will be some collection of the water's jelly at some place. So this is called false knot. False knot is just a coincidental finding. It will not do any harm. But true knot, if plenty of Wharton's jelly, this is Wharton's jelly in which two artery and one vein that is running. But if their Wharton's jelly is in adequate amount, this may not cause fetal distress. Only if it is very tight or Wharton's jelly is less in intrauterine growth restriction cases, Wharton's jelly will be less, that there can be fetal distress in those situations. So in asphyxia neonatal, what happens? There is persistence of intrauterine cause after the birth. That means baby had intrauterine asphyxia, right? So that will cause edema of the brain due to compression. Then obstruction of respiratory passage due to mucus or amniotic fluid or blood which has gone into the respiratory passage and it is not being removed adequately by the expert pediatrician. Then it will lead to paralysis of the respiratory center due to cerebral hemorrhage, because prolonged labor, obstructed labor will, or traumatic delivery will cause cerebral hemorrhage, will cause paralysis of the respiratory center. So there will be depression of the respiratory center, which could be due to anesthesia as well, drugs, methadone, congenital malformations like atelectasis or prematurity wherein oxygenation of the brain is less. All these can cause depression of respiratory center and other neural center will be depressed in these babies. Now, what happens? What is the effect of fetal hypoxia due to bradycardia? Bradycardia means less than 100, or tachycardia means more than 160. So fetal hypoxia is associated with severe complication in all systems. The fetus may suffer because of prolonged hypoxia. IUGR will be there. Fetal movement will be decreased. Oligohydramnios, because you know what happens actually. Once the fetal circulation is less, so there will be selective circulation to vital organs like brain will be there. In periphery and in kidney, less circulation will be there. That will lead to oligohydramnios. Then meconium stained amniotic fluid may be there in hypoxia, and in all these in extreme cases will cause intrauterine fetal death. The infant, how the infant suffers, if baby is born with very low Apgar score, did not cry after birth, very low Apgar at 5 minutes also, so there will be hypoxic ischemic encephalopathy will be there in the baby. Then meconium aspiration syndrome, the respiratory rate will be very high, proper, and oxygen saturation will be low. Then acidosis and decompensation will be there later on, but the child will develop cerebral palsy. In neonatal period, neonatal scissors. So if in the within 24 hours or within hours of delivery, baby has developed neonatal scissors, that means baby is suffering from hypoxic insult of the central nervous system, and this baby will have a poorer prognosis later on in life. Then antepartum fetal distress is usually, like IUGR is a chronic fetal distress, we all know. And chronic fetal distress will have a growth restricted baby, and less lighter will be there. So abnormality in the uteroplacental function on ultrasonography or clinically क्या होता है, fetal movement count बताते हैं. So when they are decreased fetal movement count, we become alert. Then we do certain tests like NST, CTG, and you can see on your screen the antenatal women is undergoing cardiotopography. So in cardiotopography, what all things we see in CTG? The rate, it should be between 110 to 160, mostly 140 rate is there. Then there are good beat to beat variation. That means more than 5 beat variation in the graph you will be able to see. 5 to 25 beats variation in that graph will be there. So that is called beat to beat variation. There will not be any deceleration. Rather, with the fetal movement, there are acceleration. So to call it a reactive NST, there should be at least 2 to 3 movement in 10 minutes in tracing, with the acceleration of 15 beats lasting for 15 seconds. So that is the normal CTG. Then another thing on ultrasonography you do is the biophysical profile score. In biophysical profile score, you see the fetal movement, fetal breathing movement, amount of liquor, amni, and fetal, and to add to it is NST. And 10/10 is the normal biophysical profile score. And if it is less, then we should suspect something abnormal. Then in amniotic fluid, there can be oligohydramnios and meconium stain liquor will be there in a distress baby. Then intrapartum fetal distress, how do we detect? By intermittent auscultation of the fetal heart rate abnormality. So how frequently? If the patient has gone into established labor in first stage, at least every 15 minutes, you should do an intermittent auscultation. And on the extreme left end, you can see with the fetoscope, the healthcare professional is listening to fetal heart sound. In the middle part, you can see that external cardiotocography has been done, and on the extreme right side, internal monitoring, wherein you can see a small electrode is applied on the fetal head. Here you can see my cursor is on the fetal scalp, wherein a small electrode is applied, and through this monitoring is done. So all the three types, one is intermittent auscultation, the other is continuous external monitoring, and third is the continuous internal monitoring labor. So that has been done. Now, normal fetal heart sound is, it is between 110 to 160 beats per minute. Any abnormality that is to be noted. Bradycardia is in labor, mostly less than 100, but some people take it 110. You should be alert at 110. Tachycardia is more than 160. Slowing of fetal heart during contraction, which recover as soon as uterus relaxes, is physiological. That is called early deceleration. With contraction, there is slowing of the fetal heart rate, and as soon as contraction passes off, the fetal heart is again picked up. This is called early deceleration. Now, if abnormal fetal heart sound rate persists for a longer time during contraction, then it is called a late deceleration, or persists beyond 3 contraction indicate a fetal distress. That means if late deceleration, prolonged late deceleration, कब बोलते हैं? Prolonged में with 3 consecutive contraction, the distress persists and it is not picking up even in between the contraction. This is called a prolonged deceleration, and it should be immediately managed for a better fetal outcome. Otherwise, we will face the problem like we may lose such a baby. Then fetal tachycardia in absence of maternal tachycardia, of course, indicates fetal distress, which I have already told you. Now, the clinical assessment, clinical examination in each antenatal visit is the primary and main assessment of fetal well-being. This includes detection of fetal heart sound. Of course, size of the fetal size is very important. पहली चीज तो हम यही देखते हैं ना, फंडल हाइट देखते हैं, फिर उसके बाद पूरा उसको फंडल ग्रिप, लेटरल ग्रिप, केफेलिक ग्रिप, पॉलिक ग्रिप, ये सारी ग्रिप, 4 ग्रिप है ना, जिसको कि हम करते हैं, फंडल है, लेटरल है, पॉलिक ग्रिप है, केफेलिक ग्रिप है. सो ये चारों ग्रिप करके हम एंटीनेटल एग्जामिनेशन करते हैं. ओवरऑल हमको इससे आइडिया मिलता है कि बेबी की साइज कैसी है. तो फीटल साइज इज इम्पोर्टेंट. Then fetal heart sound हम देखते हैं, and amount of liquor clinically, जैसे जब अच्छा liquor होता है, you are able to feel the fetal part well, fetal movements are properly felt. So clinically you can assess whether amniotic fluid is adequate or not. अगर नहीं होता है बिल्कुल amniotic fluid, तो जैसे लगता है uterus is gripping onto the baby, बिल्कुल tightly hug कर रहा है baby को, और मूव करोगे तो बहुत अच्छी तरह से ballotable है, ballotable नहीं होगा fetal part properly, that means liquor amnii कम. Now fetal heart periodic auscultation, how frequently we have already talked about, और सेकेंड स्टेज में every 5 minutes हमको करना चाहिए, क्योंकि ज्यादा frequent monitoring की जरूरत होती है. And during contraction, can you hear anyone's fetal heart during contraction? No, it is very difficult. You know, the patient, even they will throw your hand or your stethoscope away when she is in pain, and you will not be able to detect it. So just let the contraction pass off and immediately auscultate fetal heart sound. Then in intrapartum fetal heart tracing, the fetal heart beat with cardiotocography, CTG machine से कर सकते हो, और Doppler से भी you can auscultate it with the Doppler also. CTG machine की ये advantage है कि एक तो ग्राफ आता है, फिर contraction भी उसमें मॉनिटर होता है, और कॉन्ट्रैक्शन भी वो दिखाता है, और कॉन्ट्रैक्शन का और फीटल हार्ट का रिलेशन भी दिखाता है. तो अगर जो है फीटल हार्ट ड्रॉपिंग विद एट द नादे पीक ऑफ द कॉन्ट्रैक्शन नादर है फीटल हार्ट का, तो उसको आप अर्ली डिसेलरेशन कहते हो. फिर लेट डिसेलरेशन में ये होता है कि जो यूट्राइन कॉन्ट्रैक्शन स्टार्ट हुआ तो पहले तो फीटल हार्ट ठीक था, एज सुन एज लाइक कॉन्ट्रैक्शन बढ़ता गया तो फीटल हार्ट ड्रॉप हुआ, लेकिन दोनों कॉन्साइड नहीं करेंगे, यानी कि पीक ऑफ द यूट्राइन कॉन्ट्रैक्शन एंड द नादिर डेप्थ ऑफ द फीटल हार्ट या ड्रॉप ऑफ द फीटल हार्ट कॉन्साइड नहीं करेंगे, उसमें एक लैग पीरियड होता है. ठीक है. नाउ thick meconium stain liquor you get in with abnormal fetal heart tracing, which is fetal distress. Then you know fetal, sometimes you know meconium may be there with a normal fetal heart because it is a sign of maturity. But getting a meconium in any labor, you become very alert that I may be dealing with a fetal distress case, and delivery should be, we should expedite the delivery. Maybe she has reached to second stage, it's fine, she will deliver. Otherwise, like you may have to do cesarean section for fetal distress. Then in a breech presentation, we know that the buttocks is low down, and breech babies, they may pass meconium normally also when the breech part is getting compressed by passing through the birth canal. So they can pass the meconium even in the normal condition without any distress. Now, what happens if there is fetal distress? So mother's condition must be treated to prevent hypoxia to the fetus. It may be appropriate to resuscitate resuscitate before performing cesarean section. Like क्या मतलब मदर की कंडीशन को हम क्या ट्रीट कर सकते हैं? अगर उसको बार मतलब डिहाइड्रेशन है, हाइड्रेशन करेक्ट कर सकते हैं. फिर अगर उसको कन्वर्जन एक्लेम्सिया के हो रहे हैं तो हम उसको एंटी कन्वर्जन देंगे, बिकॉज कन्वर्जन जब होगा तो उसको और डिस्ट्रेस होती है. मदर को ऑक्सीजन, लेफ्ट लेटरल पोजीशन, फिर अगर उसको ऑक्सीटोसिन ड्रिप लगी है तो ये सारी चीजें हमको फौरन बंद करनी है, उसको रिंगल लैक्टेट में कन्वर्ट करना है, पोजीशन मदर की चेंज करनी है, लेफ्ट लेटरल पोजीशन है, ऑक्सीजन देना है, ये सारी चीजें जो जनरल मेजर्स होता है. So general measures to improve fetal oxygenation may help while fetal tracing is monitored. Fetal oxygen content and saturation can be improved by placing the mother in the lateral recumbent position. Administering oxygen at 8 to 10 liters per minute by mask is important. Then check maternal hypotension. If she has developed hypotension due to spinal epidural, immediately you will have to correct her hypotension. Then tocolysis, like अगर hypertonic contraction आ रहा है, जैसे हो सकता है कि ऑक्सीटोसिन से इंड्यूस थी या प्रोस्टाग्लैंडिन से इंड्यूस थी और उसको हाइपरटोनिक आने लगा है, then in that situation, apart from general resuscitative measure, you can give her a uterine relaxant. कौन सा देना होता है? टर्ब्यूटालीन, 0.25 mg टर्ब्यूटालीन दे सकते हो, और मैग्नीशियम सल्फेट लोडिंग डोज you can give and start a drip to cause uterine relaxation. Once uterus becomes relaxed, there will be more oxygenation to the fetus and the fetal condition will improve. Then PV examination should be done. If sudden fetal distress in labor develops, you must do a PV examination to check for the cord prolapse. And if there is cord prolapse, then it should be managed. And cesarean section if required. If it is because of less lighter, she is getting variable deceleration because oligohydramnios was there. So amnio infusion can also be done. So amnio infusion will also help it to relieve umbilical cord compression, and thereby it will cause improvement in the fetal heart rate tracing. Now ultrasonography क्यों करना है? For gestational age, for viability of the fetus, for amniotic fluid index. What is amniotic fluid index? How much is the amniotic fluid? It can be measured by taking a deeper pocket measurement of a deepest Liker amnii pocket, or by taking a 4-quadrant measurement of amniotic fluid. So if you imagine a uterus, just divide it into 4 quadrant, a line passing through the umbilicus and in the midline. ठीक है, एक जो vertical line है वो midline से pass है, transverse line through umbilicus है. Now in each quadrant, maximum length, depth of the Liker amnii is measured, which is free of any fetal organ or umbilical cord. अम्बलाइकल कॉर्ड कैसे अल्ट्रासाउंड में दिखती है? पैरेलल लाइंस की तरह दिखती है. तो लूप ऑफ अम्बलाइकल कॉर्ड नहीं होनी चाहिए और कोई फीटल पार्ट उसमें नहीं होना चाहिए. बिल्कुल फ्री लूप जो उसका होगा एमनियोटिक फ्लूइड का, उसमें आप मैक्सिमम डेप्थ मेजर करते हो. ठीक है. देन फीटल ब्रीदिंग मूवमेंट जो बायोफिजिकल प्रोफाइल का एक पार्ट है. फिर फीटल मूवमेंट्स. Then placental location, whether low-lying or normally situated placenta, that is to be seen, any congenital anomaly. Now, the color Doppler flow study is important for any growth-restricted. So, क्या है उसमें क्या है? Depends upon the reflection of ultrasound wave on the RBCs inside the blood vessels. So, the blood velocity and flow through these vessels can be calculated. So detection of fetal heart as early as, obviously with Doppler you can know the fetal heart at the earliest. And for monitoring of high risk pregnancy, color Doppler is very important. As I have already told you that in growth restricted baby, when to deliver will be decided by color Doppler flow study. But in every case, color Doppler is not required. Only for high-risk pregnancy, where we want to make a decision whether baby is doing well inside or we should deliver, then only you should do a color Doppler. It's not like किसी भी मरीज में color Doppler करा के हमें बहुत पता चल जाएगा. ऐसा कुछ नहीं है. Normal में नहीं कराना होता है. Then fetal distress का management क्या है? Of course, हमारा aim क्या है? Fetal perfusion improve करना और fetal oxygenation improve करना. So propped up position और left lateral position करनी है. Oxytocin stop करना है. Oxygen through mask देना है. ये सब repetition है. And then ringer lactate solution should be infused. Then if fetal heart rate monitoring persists, then you will have to expedite the delivery by normal or cesarean. That you will decide depending on the stage of labor. So you have to expedite the delivery. If early labor or head is still very high up, cesarean section, the head is low down into pelvis, you may deliver vaginally. Then what is DFMC? DFMC is a very important tool which is with the mother. So who will be there with the baby for the longest time or every time is mother. So mother will know the baby better than any obstetrician will know the baby. So how will she know? You tell her to count the fetal movement, fetal kick count or fetal movement count she is going to count. So there are different ways. In 12 hours, you can tell her that choose 1 hour each, after each major meal, like after breakfast 1 hour, after lunch 1 hour, after dinner. And in all these hours, she should have at least 3 to 4 movements, or at least like 12 movements should be there all together if she has counted in these hours. She can also count to 12, that is Cardiff count to 12. You can decide from 9 a.m. she starts counting till she gets around 10 movements. So 10-12 movements in 12 hours time is good enough. So 10 movement Cardiff count to 10 इसीलिए कहते हैं क्योंकि वो start करे movement को count करना और 10 तक count करना है उसको. Then this was about daily fetal movement count, and if any time she is not able to feel movement, she should immediately report to the obstetrician. So she should be asked to report to the doctor if she is not able to feel the movement. You know, sometimes we get unbooked cases whose baby stopped moving for 3-4 days and then they report to us कि हमारा बच्चा 3 दिन से नहीं घूम रहा है. By that time IUD occurs, so they should be very in a clear words, they should be told that any day you feel that your baby is not moving, you should immediately report to us. So the advantage is it is non-invasive. Pregnant mother can do it and no cost is involved, and accurate gestational age is not needed, but there are certain drawbacks also. You know, I still remember one of my patients, I was doing MD way back in 84, 85 when I was doing my MD. We had a very bad obstetrical history diabetic case. And she was quite obese, very difficult to hear her fetal heart sound also. So every day she used to tell my professor that baby is moving well. And she was such a high risk, 10th gravida with all babies they lost. And she was really very special patient to the professor under whom I was posted. So every day she used to ask, and she always used to say that हाँ मैडम बहुत अच्छा बच्चा घूम रहा है. और फिर जब gestational age पूरी हुई cesarean हुआ तो macerated baby was born. So that was like sometimes, you know, they interpret their bowel movement as the movement, and then they misinterpret it. So this can also happen sometimes that they are not able to count it nicely. But most of the patients, they will count. So advantage of DFMC, of course, outweigh the disadvantage, if any. And you don't give sedation to mother until unless it is really needed, or she's a psychiatric case where she's getting some sort of sedation. Otherwise, a normal patient doesn't get sedation. और अब तो प्री-एक्लेम्सिया वगैरह में भी तो कोई सेडेशन नहीं देता. पहले काम्पोज दे देते थे, अब तो कोई भी नहीं देता. तो ये सेडेशन वाली प्रॉब्लम ज्यादा नहीं आती है हम लोग के सामने. Then of course cause of distress we should know, like fever or drug if present, then appropriate management is to be initiated. If no maternal cause for abnormal fetal heart is identified, then we should look for vaginal bleeding, like abruptio placentae may be an important cause, chorioamnionitis, cord prolapse. So accordingly, we'll have to specific cause ka management bhi specific hoga. So So fetal tachycardia and absence of maternal tachycardia indicates fetal distress. We should remember that fetal distress is a manifestation of fetal hypoxia. If prolonged, it can lead to fetal death. Meconium may not be an indication of fetal distress in breech presentation. Then use of partograph is beneficial for better identification of fetal distress. Like हम एक तो पार्टोग्राम में आप पार्टोग्राफ में तो फीटल हार्ट लेते ही हो every half an hour initial and then every 15 minutes later on when good contractions are there. Then prolonged labor also you detect by doing a partograph. So partograph आपको अच्छी information.